Hello and welcome to this month's Wild World of Wounds. This month, why won't my wound heal? Part 2. Dos. Alright, so again, this is going to be a general summary of some reasons why wounds just won't heal. Each subject, again, could be a discussion in and of itself, but we're going to try and use broad strokes today just to take an overview. So last month, we reviewed time. Time stands for tissue. So what's that tissue in the wound? Is it necrotic? Does it need to be debrided? Do I have to worry about cancer? Do I have to do a biopsy? I in time stands for infection. So not just is there a wound infection, is there a deep infection? Is there a foreign body? Is there osteomyelitis? M stands for moisture. So again, we need that correct moisture balance. And E stands for epithelialization or edges. We want nice beveled wound edges, and we might need to debride the wound edges to get that. And we don't want to be putting anything in the wound that's impeding that epithelialization. So those are all kind of local things in the wound itself that might be preventing healing. Now let's go a step back and think broader. Outside of the wound itself, what else could be keeping this wound from healing? So there could be regional problems. By regional, I mean, for example, if the wound's in my foot, what's something regional in that extremity, in that leg? So blood flow or peripheral vascular disease is certainly a huge one. If you don't have enough blood flow, that wound may not heal, even if we have all the other aspects of that wound optimized. Neuropathy. So neuropathy plays a huge role. With decreased sensation, patients lose the protective response to pain, and if that's the case, they may be repetitively traumatizing that wound bed and not even realize it. Mechanical loads such as pressure, repetitive trauma, shear, friction, and edema all are local reasons why perhaps a wound isn't healing. And of course, edema plays a big role because the more edema you have, the farther oxygen has to diffuse to get to that skin, and it can also obviously affect circulation. So edema is a big one that we need to control often when we're trying to heal a wound. So there's now systemic issues. So we've talked about the local tissue level, we've talked about the regional level, and now we're going to go more systemic. What are some systemic reasons why a wound may not be healing? Well, first of all, age obviously plays a big role. So younger people, in that picture there, we can see who's more likely to heal faster. Many things change in our skin and our ability to heal as we get older. The skin becomes thinner, it's slower to repair, you have increased risk of skin tears, you have drier skin, more comorbid, more problems with your tongue. More comorbid medical conditions that might interfere with healing, and then a decreased inflammatory response. So again, under the category of systemic, nutritional status plays an important role. Protein is incredibly important for the process of healing. As a matter of fact, pressure ulcers have a strong association with protein malnutrition. So we want to make sure we're getting enough protein to heal, the vitamins that are required for healing, collagen synthesis, A, B complex, and C, the minerals and hydration and carbohydrates our body needs to have the energy to heal. Any disease process that decreases oxygen delivery to the tissues or decreases circulation or affects the immune response is going to be a comorbid condition that can decrease our body's ability to heal. So COPD, sleep apnea, obviously diabetes, and good glycemic control is very important. Cancer, diseases that limit mobility, and incontinence all play roles in our body's ability to heal. Medications, of course, play a role. So sedatives, immune suppressants, steroids decrease all phases of wound healing. They can decrease wound contraction, they can decrease wound's tensile strength, So patients on steroids, that's certainly one medication that we always think about that can affect a person's ability to heal. And under the social category, isn't this a horrible picture? I just had to put it in there, but anyway, social issues, smoking being a big one. So smoking decreases oxygen to your wound. It causes vasoconstriction. It increases platelet aggregation, and carboxyhemoglobin is not what we want. We want oxygen getting to our wound, and smoking is the perfect recipe to decrease oxygen supply to our skin. And then you want to, of course, treat the reason for the wound. So we went local, then we went regional, we went systemic, but even beyond systemic is, did we step back and think, how did they get this wound in the first place, and did we treat the underlying reason? So for venous disease, did we address it? Did we apply compression? Did we address it surgically? For arterial disease, did we have them revascularized, if possible? Did we use local treatments to try and increase blood supply to the region? Did we get them off of their smoking? For a pressure ulcer, did we offload that region? For a diabetic, did we provide glycemic control, offload them, remove the thickened callus, address their neuropathy? Time, tissue, infection, moisture balance, and epithelialization. That's in the wound. Local, circulation, trauma and mechanical forces such as edema or pressure, neuropathy, and another mnemonic that I think of to remember the local regions is circulation to my knee, knee spelled N-E-E. So circulation stands for circulation. 2, trauma, my mechanical forces, and knee neuropathy. And again, it's circulation to my knee because that's the local area, just the extremity. And then the systemic factors. So comorbid diseases, nutrition, smoking, and medications. And the mnemonic there is CNS meds. C stands for comorbid conditions, N for nutrition, S for smoking, and M for medications. CNS meds. And finally, treat any identifiable cause. All right, I hope you enjoyed this month's Wild World of Wounds. We'll see you next month. Bye for now.